A 22-year-old pregnant lady is being brought with breathlessness. She has difficulty communicating verbally and her radiograph has been presented to you. We welcome our online students. Can you please punch whether the voice is loud and clear? So typically there is no bronchovascular markings visible at all on the right side, which is very typical of pneumothorax. Whenever the air enters into the pleural cavity, there is a compression of the lung, which is tension pneumothorax. So what is the remedy for that? Chest tube insertion is considered to be the management of choice. Satyaraju is a 34-year-old patient. Typically, can you please close that door? Yeah, with audible wheeze, and his pulse is 110 per minute. And what is he suffering from? Anaphylaxis. So what is the treatment of anaphylaxis? Intravenous adrenaline is considered to be the management of choice. A 73-year-old presents with lethargy and malaise. The mean corpuscular volume is 68 and he had been recently taking clopidogrel. What is clopidogrel? Antiplatelet drug. So that predisposes to gastrointestinal bleeding, and his mean corpuscular volume being low along with the history of clopidogrel concurs with the diagnosis of iron deficiency is what you have to appreciate. A 61-year-old man presents with dyspnea, early morning headaches and daytime somnolence, and his pH is 7.37, bicarbonate is 34, and overnight nasal ventilation he is improving. What is your diagnosis? Classically, those who have Picky-Vickian syndrome, they are morbidly obese and the respiratory center depression occur in the night, and that lead to development of spells of hypoxia is what you have to basically remember. You didn't lock it, na? Don't lock. Openable. A 51-year-old with abdominal swelling and elevated CA125 and her cytology of the ascitic fluid has been shown to you. So generally a non-alcoholic patient, a middle-aged woman with ascites with no history of liver disease or alcohol excess, they should be assumed to be having ovarian carcinoma unless proven otherwise. That's the reason the diagnosis is ovarian adenocarcinoma. Now, a 49-year-old woman comes with increasing exertional dyspnea and the swelling of her abdomen and ankles, and on examination she has got tar-stained fingers on her right hand, and her jugular venous pulse is elevated and her apex beat is grossly displaced. And what do you see? Lead 1, there is a upright QRS. Lead 3, there is a downward QRS. If the QRS is upright in lead 1 and downward in lead 3, that is a left axis deviation. If the QRS is downward in lead 1 and upright in lead 3, that is the right axis deviation. Normally, QRS is upright in both lead 1 and also lead 3, like Bhangra dance. Both the QRSs are up is a normal finding. But 1 up, 3 down. See, this lead QRS is there, not up there. It is pointing down. Lead 1 QRS is pointing up. That means left axis. If this is down and lead 3 QRS is up, they both are, that is called right axis deviation. So typically if there is a left axis deviation and V1, V2, V3, V4, there are deep Q waves, which is not a normal finding. So that suggests a ischemic cardiomyopathy. The Q waves are the consequence of the previous myocardial infarction is what you have to basically remember. A 64-year-old man presents with 24-hour history of right-sided weakness with the worsening headache, and a CT scan of the head has been taken. So what do you find in the CT scan? Typically there is a opacification which is lenticular in shape, which is semilunar in shape, not lenticular, semilunar in shape, and such a type of bleed is a subdural hematoma, which is a venous bleeding. There is a biconcave disc-like bleeding, biconcave, convex, disc-like bleeding is typically epidural, which is arterial bleeding, is what you have to basically appreciate. 83-year-old woman is admitted with severe community-acquired pneumonia, and the mean corpuscular volume is 102. And the blood picture is shown, and there are cold IgM antibodies which are being found. So what do you see in the blood picture? Brisk reticulocytosis is what is typically seen. Multiple reticulocytes you are able to see in the peripheral smear. Whenever anemia has a significant reticulocytosis, what kind of anemia it is? Hemolytic anemia. Remember that rule. Why? Because bone marrow is producing RBCs. But once they are releasing out, the antibodies are destroying them. But still the bone marrow retains the ability to reproduce the RBCs. So it will overtly reproduce and produce a lot of reticulocytes, and that's how reticulocytosis is a typical feature, is what need to be remembered. A 22-year-old woman with hypopigmented patches on the dorsum, and she has got weight loss, loose stools, oligomenorrhea, and typically her nails have been shown. So which endocrine abnormality lead to development of pachydactyly? It's all called thyroid acropathy, it is called as. So thyrotoxicosis, classically they are called plumber's nails of thyrotoxicosis, is the shooter which you have to basically identify. A 36-year-old woman underwent an operation for perforated appendix. She has been vomiting today and feels distended, and hemoglobin is 13.2, potassium is 3.4, and central colicky abdominal pain, and her radiography is showing air fluid levels which are centrally located, which is very classical feature of small bowel obstruction, is what you have to basically understand. A 50-year-old woman presents with a history of chest pain along with regurgitation of solids and liquids, and dilated esophagus is there with the tapering of the end towards, what is this appearance called? Rat tail or beak appearance, which is more typical in case of achalasia, is what you have to basically appreciate. 69-year-old with a long history of dyspepsia, and she has got a thoracic dysphagia to solids associated with the pain on food reaching the sticking point. The pain on food reaching a sticky point is a very classical feature of stricture. So what the radiography is showing is basically a esophageal stricture, is what you have to appreciate. Pain on reaching the sticky point is? Sticking point means the patient says, doctor जरा खाने में लटक रहा है अटक रहा है. The moment the food is reaching that atakne wala point, then the pain comes. That is the typical nature of stricture. Then 41-year-old is referred with worsening epigastric pain and dyspepsia. So NEET PG is supposed to contain at least 50 to 60 image based questions. So they will be more or less very easy if you know common radiographs in Bailey and Love, Davidson and all these books, but mostly using the clinical vignette and the history, you should be in a position to make a diagnosis and pin down the answer is what you have to appreciate. Somebody is waiting also. Ask him to sit there. Yeah. So, upper GI endoscopy confirms multiple peptic ulcers in the stomach and duodenum, and there is ulceration in the lower esophagus, and his serum gastrin levels are grossly elevated, and what you are finding is multiple ulcers in lower duodenum. So typically whenever multiple lower duodenal ulcers are there and the grossly elevated serum gastrin levels, then you should keep it open. You should think of Zollinger-Ellison syndrome is what you have to basically remember. So you should know all the various causes of hypergastrinemia basically. Now, a 22-year-old in her 4th pregnancy and complaining of abdominal pain, and her pulse rate is 98, BP is 100/60, and vaginal examination there is no bleeding, and she has got a history of falling down. Trauma is a predisposing factor for a sudden separation of placenta leading to abruptio placentae. So that is the reason we should contemplate possibility of abruptio. What do you see in this ultrasound? There is a placenta and a retroplacental hematoma. It is also called concealed hemorrhage, is what you have to understand. Now, a 27-year-old, 37 weeks of gestation, preeclampsia, blood pressure is 140/90, and her cardiotocogram is reactive, and she requests pain relief, and her BP is 80/60. She shows decelebrations and IV fluid has been given. So what is the next best treatment that you want to give? So fundamentally, hypotension after epidural anesthesia is usually a situation which settles by giving IV fluids. But if it is persistent, patient becoming symptomatic, and if it is persistent in spite of giving fluids, then it is an indication for giving a sympathomimetic agent to lead to vasoconstriction, and that is where you will give phenylephrine. Now a 26-year-old woman, hepatitis B surface antigen positive but envelope antigen negative. So she is a mother with low infectivity because of the negative hepatitis B envelope antigen, and such scenarios they need to give neonatal active immunization with the vaccination. No need for giving passive immunization is what need to be remembered. Passive immunization means giving immunoglobulin. 28-year-old, first pregnancy, admitted in labor at 37 weeks, and she has got elevated alkaline phosphatase. Bilirubin is 20 and aspartate aminotransferase is 100, and she is having 3 contractions every 10 minutes. So she has got a meconium stained liquor. Then what is the best investigation and treatment? So there are 4 conditions associated with jaundice in pregnancy. One is hepatitis B, very common cause. Second is obstetric cholestasis. In pregnancy, cholestasis can occur. Third is there could be eclampsia with HELLP syndrome. That is hemolytic, elevated liver enzymes, and low platelet count. Then there can be PUP, PUPP, PUP. Not associated with jaundice, but PUP is another common entity. A lot of questions come. Then acute fatty liver of pregnancy is another very important close differential. So which of these 5 conditions they recur, which has got good and bad prognosis, all these things you have to be 100% sure. So doctor, 22-year-old primiparous woman, and she has a increase in urinary frequency. Almost 20 times she is passing urine every day. On examination, uterus is non-tender. There is a suprapubic tenderness along with bilateral flank tenderness, and the maternal temperature is 38.6, and her urine analysis shows a WBC count of 100. So what is the best investigation? Always, for a pyelonephritis, the treatment is antibiotics, which is dictated by the culture studies. So there is a reason midstream urine culture and then initiate intravenous antibiotic is considered to be the management of choice is what need to be remembered. A 30-year-old is having a long-standing Crohn's disease. There are multiple fistulae around the anus which are associated with abscess formation, and what is the best treatment? Drainage of the abscess is considered to be the most important part of treatment. Anywhere be the abscess, there is a general rule. Now let us take up some of the questions in medicine. So next week you have the DNB exam. After that your guns are ready to fight against the forthcoming NEET, most likely in November, December. From the month of September onwards, we will have bi-weekly exams of the NEET PG pattern in order to scale up to the NEET exam to be there in the November last week. So meanwhile, if the state entrance changes its mind and say no NEET this year, next year, and this year state entrance only is there, one more chance you will get it to fight after the November NEET is over towards March. So hope that meanwhile you clear the DNB, because clearing DNB is like a well built, well nourished, moderately built, moderately nourished PG entrance aspirant. If you can't even clear DNB, forget about the dream of clearing state entrance or NEET PG. So that is a minimum benchmark which you have to set yourself. So the most common site of abscess in the brain, typically the place where grey matter, white matter junction is there, that is the place where vascularity is there, which is a watershed zone. And most of the times it is the hematogenous spread by which the brain abscess will be reaching is what you have to basically understand. So what is the pain of myocardial ischemia? It is typically induced by exercise and it is relieved by rest. And if you take the aortic regurgitation or a severe anemia, beriberi, thyrotoxicosis, patent ductus arteriosus, or any diastolic runoff of the blood, in all those hyperdynamic circulatory states, you will have the collapsing pulse sign typically becoming positive. Normally, whenever we have inspiration, there is a negative intrathoracic pressure that sucks the blood from the jugular vein into the right heart. So JVP is supposed to collapse during inspiration normally. If it doesn't collapse, then think of constrictive pericarditis is what you have to basically understand. Now, typically, where do you find a reversed splitting of the heart sound, second heart sound? Normally A2 occur followed by P2. But if there is any left bundle branch block, the A2 become delayed. So delayed that it occur after P2, which is called reversed splitting of second heart sound. Now, the various drugs and their adverse effects. It is the amiodarone that lead to corneal microdeposits. In fact, all side effects of amiodarone you have to have in tips. Definitely asked question. Yes, amiodarone is the one which will have corneal microdeposits, not propafenone. Amiodarone also has photosensitivity. Verapamil, there is a constipation being a calcium channel blocker, and digoxin can lead to acute confusional state. So what is meant by PR interval? PR interval is from the beginning of the P towards the end of the PR segment, which is until the beginning of the Q, is basically called PR interval. So interval typically contain a wave and the isoelectric segment together. That is a point. Once more, doctor, all these intervals, QT, corrected QT interval, 400 milliseconds or 0.42 seconds. Then what is a normal PR interval? When do you call first degree heart block? All these funda, you have to nail them down and go to exam. Now, jugular venous pulse, if you take, Tricuspid stenosis will lead to giant A waves. A wave occurs because of the contraction of the atrium. If there is a tight stenosis, that contraction occurs against the narrow AV valve. So that increases the pressure in the atria, leading to giant A wave. Tricuspid regurgitation lead to large B waves. So all these are the things which we already discussed in JVP. So whenever you get doubt, go to the anatomy2medicine.com and go to that particular video. Both theory is available, MCQs previous years, DNB, everything is available as a discussion there. So you have to just review that. Now, atrial fibrillation. Typically, what is the wrong statement about it? Whenever you give anticoagulant therapy, you can very much give DC cardioversion after giving significant amount of anticoagulant therapy. Now, megaloblastic anemia typically can be associated with pancytopenia, and it can lead to hypersegmentation of the neutrophils. If you look at their nucleus, multi-segmented nuclei will be found, anisocytosis, poikilocytosis. They are all the features which are typical in case of megaloblastic anemia. Then hemolytic anemia is a complication of which situation? Typically, megaloblastic anemia, mycoplasma, prosthetic heart valves, they all lead to what is called, if you take prosthetic heart valves, what is it called? Microangiopathic hemolysis. Mycoplasma will produce cold antibodies and lead to hemolysis. Megaloblastic anemia lead to ineffective erythropoiesis and hemolysis of the blood vessels while they are leaving the bone marrow. So they are all the things associated with the hemolysis, hemolytic anemia is what need to be remembered. Now the typical features of polycythemia rubra vera. It's a myeloproliferative condition. That's the reason the lab score will be higher than normal is what you have to understand. Now in acute renal failure, what happens to urine osmolarity? Urine become typically concentrated urine and more than 600 milliosmoles per kg. If you find, then that means to say that ARF is basically a pre-renal ARF where tubular function is still intact and it is secondary to hypovolemia and a dehydrated condition. Long-term dialysis, what are the complications that can occur? Long-term dialysis patients are vulnerable to atherosclerosis, so myocardial infarction, carpal tunnel syndrome, high output CHF, they are all the complications that occur in the patients. Why high output CHF? Because you put an arteriovenous fistula in order to run the hemodialysis. So that can predispose to high output failure. Then Fanconi syndrome, typically what are the features? So it leads to proximal RTA, glycosuria, decreased uric acid because there is a uricosauria, and decreased phosphate and amino acid urea. They are all the features. So it is not hyperuricemia but decreased uric acid. That's what you see in Fanconi. Myeloma kidney lead to proximal RTA but not to distal RTA. So you must know the list of conditions leading to proximal RTA, distal RTA, etc. etc. To prove any endocrine deficiency, what will you do? Provocative test. To prove any endocrine excess, what will you do? Suppression test. So we use TRH as a provocative agent to prove the prolactin deficiency. Now all hypothalamic centers, doctor, you should have them in your tips. Anterior hypothalamic center is associated with cooling. You can remember a car. Anteriorly what you have? Radiator. It leads to cooling. So anterior hypothalamic center is cooling. You have a sunroof. When you see to start stars, you want to go to sleep. So, suprachiasmatic nucleus, it's like sunroof. It is responsible for our circadian rhythm. Whenever you put a sunroof in the car to see the stars while night you are traveling, right? Then laterally you have a gas cap to put ignition. So that is the hunger. The moment you open the cap, hunger only makes you open the mouth, no? So it is that lateral nucleus. Medially you have got the tank, petrol tank. So medial is basically what? Filling. If the filling is full, you get fullness. So satiety center is medial. And posteriorly you have an exhaust. So all heating is posteriorly, cooling is anterior hypothalamic nucleus. So you remember the car, you remember the nuclei. Another way is stim the lad, get fat. Lateral area is for obesity. Stimulating lateral hypothalamic nucleus increases hunger. Ventromedial, stim the ven, get thin with leptin. So medial, stimulating ventromedial increases satiety and stimulated by leptin. This also please remember, leptin has effect on what? On the excess leptin lead to, it stimulates ventromedial and increases satiety. Whereas leptin inhibits the lateral area and inhibits the hunger. So high leptin is good for becoming thin, and obese people have got low leptin or resistance to the leptin receptors. That's what you need to remember. Anterior is cooling, AC, easy to remember. Posterior is shivering, and shivering produces heat. That's what you have to basically remember. Now, whenever the pituitary is damaged, you are developing hypopituitarism. What is the order at which you lose the hormones? First growth hormone, then FSH, then TSH, lastly ACTH. That's a typical order. Isolated elevation of alkaline phosphatase is a feature you see in IBD, diabetes, Hodgkin's. It is the hyperthyroidism that leads to isolated alkaline phosphatase elevation. Lot of people come to you with the LFT. Doctor, see, my liver is damaged, my alkaline phosphatase is elevated. Even if patient has diabetes also, only alkaline phosphatase elevation can be seen. It does not always mean some sort of a obstructive jaundice or whatever. That's what you have to be very sure in interpreting the LFT. Then interferon therapy in chronic hepatitis B. So where do we use it? If there is already a decompensated liver disease of a high grade Child's score, Child's cirrhosis score, then there is a contraindication for giving pegylated interferon. This is called Pegasus. Pegylated polyethylene glycated interferon is what we basically administer. Very costly therapy. Patient should be ready with a lakh rupees if PEG therapy is planned. Now, what is not a stimulus for ECF expansion? It is the peripheral arterial vasodilation, not constriction, is a stimulation for ECF expansion. Now, postoperative fluid management. You don't need to replace millimeter by millimeter the urine lost. All the remaining statements are true. Insensible loss is 600 ml per day. Insensible loss may increase to 1500 ml per day. And remember, doctor, fluid electrolytes management. These are the two areas. If you are good, you are a good MD general medicine. Now, what are the components of Hasselbalch's triangle? Middle border of rectus sheath, Cooper's ligament and inguinal ligament are the ones which are the borders, as all of you know very well. Now, Bassini repair. Does it? The Bassini repair, and what are the modifications of Bassini repair? Schuldeis's and McAvey's. If you have done this question wrong, just quickly review. Inguinal canal, inguinal hernia surgeries is one of the favorite area for the NEET PG or DNB or any exam. These repairs create a tension in the suture line. That's the reason the recurrence rate is very high, is what you have to understand. Now, the echo is showing 25%. That means there is a significant amount of cardiomyopathy. So, which trace element deficiency lead to Cashon's cardiomyopathy? Selenium is what you have to basically remember. Now, what is meant by euthyroid sick syndrome? Whenever the patient is acutely ill, then what will happen, doctor? Acutely ill patient, if he is there, then his thyroid function test will abnormally elevate. And though he is clinically euthyroid, still his LFT, thyroid function test only will elevate. There's a reason whenever a patient is acutely admitted in the hospital, don't order for thyroid function test because it is difficult to interpret. So the patient will not be hypothyroid. He will be a euthyroid patient is what need to be remembered. Now, you want to evaluate the bleeding in surgical patient. So, what is the most common cause of surgical bleeding? It is the incomplete mechanical hemostasis which is responsible for surgical bleeding. Now, hereditary hemostatic disorders, let's talk about them. Whenever the patient is having the bleeding diathesis and you want to replace his clotting factors, if you take the factor 5, it is called a labile factor. There's a reason a stored blood sample, blood transfusion will not help. You need to give a fresh plasma, otherwise you won't have adequate amount of labile factor. Now, what is the very sensitive method to know prostate cancer? Do both digital rectal examination and also prostate specific antigen. Then inflammatory bowel disease comes under secondary amyloidosis, whereas multiple myeloma, Waldenstrom macroglobulinemia, non-Hodgkin's lymphoma, anything related to immunological disorder is primary, is what you, that list of table, what are primary, secondary amyloidosis, what type of amyloid deposition occur in which situation, everything you must be ready, doctor. Now, regarding rigid abdomen and free air on plain film. Now, suppose if a patient is having on examination rigid abdomen, plain radiography showing air in the diaphragm, you don't need to waste time on what you call getting a CT scan or any other investigation. It is like tire puncture. Take out the stepney and then put it. You are on the highway. So you have to do a laparotomy, identify there is a leaking area, the seal, and then you need to do a repair of that. Otherwise you lose the patient if you waste time in doing a lot of investigations. A 35-year-old woman with acute onset of epigastric and right upper quadrant pain. She has similar episodes in the past and she has fever and non-bilious vomiting. Then what is the cause of abdominal pain? So it's a classical clinical history of cholecystitis. Now, what is the ominous sign in a patient who has got abdominal pain? If there is a jaundice plus abdominal pain, that is considered to be a very dangerous combination of clinical features which you have to evaluate. For a CABG, What are the contraindications? Any diffuse disease and heart failure. Small diffusely diseased arteries or moribund patient after resuscitation, they can't be taken for surgery. But acute MI over 2 hours old is not treated to be a contraindication. Small diffusely diseased arteries or diffuse disease with heart failure or acute MI over 6 hours old or a moribund patient. They are the contraindications for CABG. Now coming to the aortic regurgitation, what is accept about it? Now the indications when to operate and do a valve replacement in aortic regurgitation are very, very clear. So any NIHA class 3 or class 4 symptoms, so they are all included, but asymptomatic patients with LV dysfunction during exercise by itself is not an indication, is what you have to understand. They can very well be managed by medical therapy. Now regarding pancreas, serous cystadenomas versus what is the other type? Mucinous. Mucinous are more often malignant, is what you have to understand. Now what is the wrong statement about this? Valvulae conniventis are the hallmark of jejunum, not ileum, is what you have to appreciate. Now coming to diverticulae, most of the diverticulae are along the mesenteric border, not the anti-mesenteric border. But Meckel's is on the anti-mesenteric border. But most of the other diverticulae are all along the mesenteric border. Now ulcerative colitis, lowest complication rate is there for proctocolectomy and ileostomy. Procto is rectum. So you excise rectum, colon and then put a ileostomy, he has got the lowest amount of complication rate. Ulcerative versus Crohn's. It is the Crohn's that affects the terminal ileum that mimics the appendicitis in its clinical presentation. Then abscess and fistula formation. Ulcerative colitis versus CD. If you take, which has got a more often a feature, Crohn's. Crohn's is transmural. That's the reason it has a greater chance of developing fistulae. Regarding familial edematous polyposis, is it a short arm or long arm is what examiner is going to twist your arm. Then left-sided tumors versus right-sided, what is the main difference? So left-sided tumors present with rectal bleeding, alteration, bowel habit, tenesmus and obstruction. Right-sided tumors, iron deficiency anemia and abdominal mass is the presenting feature. Coming to stomas, ileostomy effluent is usually liquid, whereas colostomy is solid. Ileostomy are more likely to develop fluid and electrolyte balances because more often the effluent that comes out of ileostomy is liquid, is what you need to understand. Now, appendicitis in any other location can lead to rigidity, but not retrocecal. Retrocecal is hidden behind the cecum, so rigidity is not a feature. Inferior rectal artery is a branch of internal pudendal artery. Superior rectal artery is a continuation of inferior mesenteric artery. So you have to be very, very sure in the anatomy. Examiner ruthlessly asks every exam. This is the favorite question. You have done urodynamic studies. What is a wrong statement in this? Residual urine is generally less than 50 ml. First desire to void urine comes at 150 to 200 ml. The normal capacity of the bladder is 400 to 600 ml is what you have to basically remember. Now, you will do androcolporaphy to treat cystoerythrosil. But what is the condition? Patient should not have stress incontinence. If there is stress incontinent, it is against the indications. Now, you must be quite sure, endometrial, ovarian, cervical, carcinoma, how to stage them. Definitely one question out of these three carcinoma staging will definitely come. Now, a 56-year-old woman, after coughing or jumping, she is having a loss of urine. But she occasionally loses urine while lying in the bed. If she happens to cough vigorously, she is unable to stop the urine once it has begun to flow. Now, the common difference between whether it is benign stress incontinence is a very commonly wrong answer versus diffuse or dyssynergia. How do you differentiate? The loss of urine in recumbent position and inability to stop the urine loss once the stream begins is the classical feature of diffuse or dyssynergia, is what you have to basically appreciate. 46-year-old, benign stress incontinence, Kegel exercises have not helped and her incontinence is worsening. Her urethrovesical junction is prolapsed into the vagina. Then what is the procedure more likely to cure her incontinence? So typically, the Birch procedure and Marshall-Marchetti-Krantz procedure are the most common retropubic procedures, is what you have to appreciate. Then, anti-immunoglobulin, in which scenario it is not required. At 40 weeks you won't give, but threatened abortion and first trimester bleeding, or genetic amniocentesis at 16 weeks gestation if you have done, etc. etc. Then what is lower uterine segment after all? After all, lower uterine segment is the one that develops from the isthmus, not the internal os, is what you need to remember. Corpus luteum functions up to 10 to 12 weeks and maintains pregnancy, is what you have to remember. HCG peaks at 60 to 70 days. Bluish vagina is what sign? Chadwick. Then chorionic villus sampling is for the chromosomal analysis. Down syndrome is diagnosed by chorionic villus biopsy if the gestation is 10 weeks. Then uterus didelphys has got a fully developed horn. That's the reason it does not lead to recurrent abortions. Incompetent os lead to painless abortion, not painful. Then 3 months amenorrhea, abdominal pain, retention of urine. Classical of ectopic pregnancy. If the ectopic pregnancy, if it develops a hematocele in the pouch of Douglas, it can lead to retention of the urine and also leads to abdominal pain, is what you need to remember. A woman develops a red degeneration, most often is managed by conservative management and sedation. You don't give antibiotics for that. Ovarian cyst is 18 to 6 centimeters in the right fornix, and best way to treat is ovariotomy in the second trimester. Now, high risk for ectopic pregnancy. Typically, previous ectopic pregnancy, previous PID, IUCD user, they're all the ones. McAfee's treatment in placenta previa, which is a conservative management. McAfee is nothing but conservative management. Main idea is to salvage the fetus if it is alive but premature, provided the woman is not bleeding heavily. Once the fetus reaches maturity, or if it is dead, termination of the pregnancy is the one which is basically recommended. So they are the main questions of medicine, surgery and gynops, doctor. So good luck for your DMB